Hello, can everybody hear me okay? If you can't hear me, send me a question
No.
and I can. Okay, can everybody hear me? I'm going to begin talking. We'll run through the webinar here. We'll cover intro to ALD AMN, how ALD is inherited, what does the ALD gene do, what to expect if you have the ALD gene, and a brief coverage of how you can stay healthy. We'll leave a good amount of time for question and answers if we can, so I will try and move through the talk so we can address questions at the end. We'll stop at 5 p.m. Eastern Standard Time, so in about 50 minutes or so. So as a background to ALD, ALD is a genetic disorder. It results in the accumulation of certain kinds of fats in the nervous system and adrenal glands. This results in a complex array of symptoms that affect the body and the brain. And I put a picture here of the very long chain fatty acids that can accumulate in ALD. And this is, we think, one of the sources of the cellular and organ injury in ALD. We'll go into a bit more in the way of details about the pathogenesis in just a moment. I want to mention that we have a wonderful video on the topic that covers the large portion of what we're going to be talking about here in about 5 minutes with a nice illustration. So if you haven't seen it, it's on the ALD Connect website under the webinar section. But as a very basic background about DNA, genes, and proteins, as most of you know, each cell contains all of the DNA that makes us unique. DNA contains coding for genes that then code for proteins. And changes in these genes occur naturally on a regular basis as we move from one generation to the next. In fact, this is what makes us all different. This is a natural part of biology. This is part of life in every form. The gene mutations, many are helpful, many do nothing, and some can be harmful. And the ALD gene mutations, as we know, can be harmful for many people. But we will talk about both the perils and the hopes as we get toward the end here. But I did want to cover, give you a picture. This is a schematic of what the ALD protein looks like. Years and years of research have provided us with a sense of what the gene looks like and where the mutations occur and cause problems. And each dot on this schematic, each little bubble, represents an amino acid, and the colored bubbles represent amino acids that, when changed, can cause problems. And there's a nice coding there. So you may know the gene related to a family or a close friend, and you can reference it here if you so choose. But this is really just a schematic representation to provide people a nice visual of. Let me make sure I'm not muted here. Okay, I think you guys can hear me still okay. But a nice schematic here of what the protein looks like. So for ALD pathogenesis, we start with the ABCD1 gene mutation. This leads to poorly functioning ALD protein on the surface here. This leads to disabled transport of these proteins, or sorry, of these fats into the peroxisome, where they're normally broken down into smaller fats. When they can't move from this large fat to this small fat inside the peroxisome here, they get a buildup of these fats. These fats accumulate in abundance in the cells of specific organs, particularly in the brain, in the adrenal cells, and in the blood cells. And this then leads to problems further down the road. So how is the gene inherited? As many of you know, the gene actually sits on the X chromosome. And women have 2 X chromosomes, men have 1 X chromosome and 1 Y chromosome. This is the schematic. The light-colored people, not the dark-colored people, but the light-colored people are the affected gene carriers. So fathers can only pass the gene on to their daughters. Mothers can pass the gene on to both sons and daughters. So if you're joining the call, I'm going to assume that either you or a family member or a close friend has been affected by ALD, and that someone you know carries the ALD gene. And so the question is, what should you expect as a carrier of the ALD gene? And I like to say in many ways, our expectations for life are determined to a large extent our experience of life. And so I think, well, there can be expectations that can be fearful. There are also expectations that can be helpful and help us anticipate, expect, and adapt to changes rather than be shocked, surprised, and unnecessarily hurt by them. So with that in mind, let's talk about expectations for ALD. So the good news is that many people with ALD do remain asymptomatic for a long time. And this is good if you're a carrier in the sense that you can, in many ways, go about life as you always have with no symptoms at all. This is true more so of women who tend to have symptoms develop later in life, less so of men who have symptoms develop earlier in life. The bad part of this is that we often don't know until a late stage when people are affected by the disease, and I'll speak briefly to the relevance a little bit later. So let's start with the experience, again with the expectations of what to expect in boys and men. So here's a schematic of the possibilities of experience for men. I apologize, it's a little bit clustered, but let's focus on one line at a time. So the green line to begin with is a line that represents a man's likelihood of having adrenal insufficiency at any point in time. And you can see it increases as you get older, but it doesn't really go to 100%. There are some adult men who don't have significant adrenal insufficiency. The blue line represents the symptoms and spectrum of AMN, which include symptoms we'll talk about in a moment, but mostly trouble walking, trouble with balance, trouble with bowel and bladder function. And you'll notice that essentially all men by the time they're 50 have symptoms of AMN. The red line represents the possibility that at any age an individual will have cerebral ALD, the most famous and feared form of the disease that involves brain inflammation and demyelination. And to state it briefly, boys between the ages of about 3 and 12 have a 35 to 40% chance of developing brain inflammation. The risk falls for reasons that are not known dramatically thereafter, but remains, and adult men can develop brain inflammation later in life, although their risk is lower. Only about 20% of young adult and adult men will develop brain inflammation. So to talk a bit more about brain inflammation, what we call cerebral ALD, or in the case of childhood, onset childhood cerebral ALD. These are images from various patients. You'll notice the first MRI really appears normal. This is from a 5-year-old boy with ALD, his first scan. You'll notice that a few months later, when he's rescanned, he has a small lesion at the back of his brain. This is the beginning of inflammation. If this is not the same boy, but this is another boy who was caught later in the progression of disease. And this is what the first boy's lesion would look like if it were untreated for an extended period of time. Fortunately, for boys with this disease, if we catch it early at this stage here in particular, or even at slightly more advanced stages, we can assess the boys for bone marrow transplantation or cord blood transplantation. And this is a very effective treatment that halts the disease. It doesn't reverse the injury, but it halts it.
Keith, we can't hear anything.
So the experience
that they haven't heard for the past minute.
Trying to adjust the audio here. I'm told there's a little bit of an echo. So if there is, my sincere apologies. Bear with me. I'm working with microphone here, but it doesn't seem to be cooperating. In boys with adrenal insufficiency, most, but not all, in boys with ALD, most but not all will develop adrenal insufficiency. The signs and symptoms can be life-threatening and include fatigue, nausea, vomiting, low blood sugar, low blood pressure, lightheadedness, coma, and seizures. This is easily treatable with steroids. So for men with AMN, a report from 96 men with AMN suggests that walking and balance problems are common. They begin at around at age 28, although they can have their onset later or a little bit earlier. The plus minus represents kind of the variation. So as some people have as far as 8 years or more later, and some years are more earlier than this. Pain, numbness, tingling in the legs began at around age 33 for most men, plus or minus 10 years. Urinary problems begin at 33 plus or minus 10 years as well. bowel urgency or incontinence begin a little bit later. So what about women with the ALD gene? Women with the ALD gene, as I mentioned, have fewer symptoms and often a later onset. But I know that many women in the ALD community have felt as though many doctors were not understanding that that women do indeed have symptoms when carrying the gene. And a recent publication by Mark England and colleagues really defined this in the clearest way for the first time. And what they found was surprising, I think, to many of us who've been in the field, in that women were experiencing symptoms at higher rates and a little bit earlier, in slightly younger ages than we might have anticipated. Although many remained asymptomatic early in life, many became symptomatic in their 40s and later. And the symptoms that were most problematic were bowel and bladder problems, as well as peripheral neuropathy, walking, and balance problems. So I think we can all reiterate the experience of women who've been saying for years and years that they really have problems that are very bothersome. And my advice to women who maybe are not getting the sort of attention from their physicians that they need is to mention this publication to their doctors. And the approach here would be very similar to the approach, and then the symptoms are very similar. So what can one do to stay healthy with if you're carrying the ALD gene? I would say, first, you can let your doctors know that there are ALD care guidelines recently published. 2012, Mark England and colleagues published a very, very helpful set of guidelines that has been useful for providers in the field and provides a very nice algorithm for new diagnosis in ALD. I'll qualify that by saying it really is a guideline primarily for treatment of boys and men with ALD, but it provides helpful guidelines nonetheless in that boys diagnosed with ALD should be referred to an endocrinologist for routine screening for adrenal dysfunction. They should have an MRI at the time of diagnosis, even if they have no neurologic symptoms. In fact, the purpose of the MRI is primarily to catch early signs of neurologic disease, brain inflammation, before the patient develops symptoms. That's when bone marrow transplant, abbreviated here with HSCT, which is hematopoietic stem cell transplant, is most effective. It's most effective if we catch it early, even before symptoms begin. This is really, as I mentioned, boys between age 3 and 12 are at highest risk for this. And so this is the time when we are screening most frequently. We try and screen about every 6 months with an MRI. For those that don't have that are outside this window, older than 12 years of age, we repeat the MRI every 12 months. So current medical therapies. For asymptomatic boys aged 3 to 10, Lorenzo's oil is been shown to be modestly effective in reducing the risk of brain inflammation. This is only true if it started before brain inflammation. It does not have any effect after brain inflammation begins. So the idea is to begin Lorenzo's oil in boys who do not have any signs of neurologic disease. For men and the very few number of women who have adrenal insufficiency, daily oral steroids are very effective, very easy to implement, and life-saving. An endocrinologist would be responsible in caring for you and managing these symptoms. For cerebral ALD, a prompt evaluation for bone marrow transplant is really going to be the key. You want to catch it as early as possible in the course of disease. And for AMN, the treatments are symptomatic. There are treatments that can help with the symptoms of AMN. These symptoms include Ampera for walking, so known as 4-aminopyridine. It's been helpful to not all men, but some men with AMN. Men with spasticity, things like baclofen, administered orally or through an implanted pump, can be helpful. Things like Neurontin or gabapentin can be helpful for nerve pain. And a variety of other medicines can be helpful for both bowel, bladder, and sexual dysfunction. So what can you do in addition to the doctor's visits to stay healthy? Healthy diet, high in vegetables, and low in sugar. General health, the good health guidelines are probably helpful. Moderate level of exercise, including one that you may devise with rehab therapists. I put healthy interpersonal relationships in here, only because that we know that in every illness and ailment we know of, healthy interpersonal relationships are very helpful and very enriching and a helpful part of life. Regular visits with your neurologist, physical therapist, endocrinologist, urologist to address your symptoms specifically, and as always, a good general practitioner who listens and is attentive and responsive to your needs and able to give you guidance is essential. We're working on establishing a referral network so that individuals all over the country and we hope all over the world eventually will be able to find someone that's reasonably close to them and help mitigate some of the great expense that some people are taking up to visit doctors all over the world. So I will say a couple more things here that we want you to stay tuned. This is we're near the end of this session, but I'm going to take questions here in a moment. I do want to mention that we're going to be having additional webinars, including updates on current and emerging therapies for ALD, AMN, future clinical trials, and so on. I want to mention a very special thanks to Ines Fang and Tara O'Meara, who really spearheaded this webinar. Deep thanks to both of you. Kathleen Fortin O'Hare, who helped put together many of the guidelines we've been using for these webinars. Ali Fatimi, Florian Egler, who are helping with this webinar, will be presenting future webinars. And the ALD community of patients, families, doctors, and scientists, and to all of you for joining. So I do want to mention that the information and services we're describing here are really for informational and educational purposes only. We're not trying to offer, and we can't, in good faith, offer medical advice over the phone outside of the diagnostic visit. But we hope that the information has been helpful to you to at least know where to start and when seeking medical care. And we will be recording this webinar for future broadcasts. Okay, so I'm going to take questions here, but before I do, I just want you to keep in mind that we are going to be taking information on future webinars as we go ahead. So at the end of this session, you'll be receiving a 4-question survey, so if you could please fill that out, that will be wonderful. Will help us devise the next set of webinars. So I have a couple questions here that we will be answering. First one is from a member of the ALD Life. Welcome. It says, do endocrinologists test very long chain fatty acids in idiopathic adrenal insufficiency? Suggesting that it's a variable task and it's variably done in the UK. So I can say that the guidelines for endocrinologists with idiopathic, meaning causes unknown, with adrenal insufficiency of unknown cause, do recommend screening for very long chain fatty acids. I know that's the practice within the US. I'm less familiar with the practice in the UK, but I would think that it would be similar there. And the reason that's important, as I think the questioner is implying is that it is an important practice to pick up children and adults with ALD early enough to screen for brain disease and other symptoms. So that's a very good question, Karen, and I think it's been actually the focus of one of our outreach efforts is to connect with the endocrinology community to make them aware of ALD and encourage them to ask or to screen their patients for ALD in that setting. There's a question about what % of women develop cerebral ALD. The number is, I can only say, very small. There are only case reports of women developing cerebral ALD. It is possible, and it has happened, but it is below 1%.
Yeah, so
here, I have Ali Fatimi on the microphone here. He's going to speak to that question.
yeah, hi there. So we actually had a study where we looked at the series of women that we can be pregnant about 10 years ago. And it included around 90 women. And out of these 90 women, there were 2 individuals who had developed cerebral disease. Both of them were girls, young girls. One was, I think, 8 years old. The other was 13. And they had the pretty much same kind of MRI pattern as we see in males. And the assumption was that in them, the good X chromosome, the one that did not have the mutation, was skewed or inactivated. But that's, as far as we know, the only 2 cases. There were a number of women who had changes on the MRI that were interpreted by some doctors as potential white matter lesions related to ALD. However, they did not look like what the males develop. And at the same time, actually, when you compare them to age-matched controls also have white matter changes, which is basically age-related. So we really think that the chances are extremely low that a woman develops cerebral disease.
Much thanks, Ali. We're fortunate that we're at a conference together, so it becomes a good fortune of having a couple of us here in the same room. So a few more questions. Someone is saying, I'm a female carrier, age 50. I currently have no symptoms. Does that mean that I will not get any symptoms in the future, or is there still a chance for me to develop symptoms even at my age? I think the answer is that it's wonderful actually that you don't have any symptoms yet, and the likelihood is that any symptoms that do appear are going to be maybe less severe than they might. They always begin small, but there is a possibility that you could still develop symptoms. I think it's fair to say that there may be women who don't develop any significant symptoms even as they move into later decades. But to our knowledge, many do. I would hold open the possibility that yes, it is possible your symptoms will never be too significant. And I think I can leave it at that. Any other thoughts from the group here? Thank you. Another question. Why do some boys get an MRI without contrast and some get with and without contrast? That's a good point, and it's a good technical question. Actually, boys should all be getting MRIs with and without contrast, and the reason is that contrast is used to measure injury to the barrier of the around the brain that separates it from the blood. When that barrier comes down, that's when that's a sign that brain inflammation has begun. That's a very important marker of cerebral ALD. So we do MRIs. We do in the same session. We'll do one set of pictures without contrast, and then we do one set of pictures with contrast, and we compare them to see if they look different in the brain. And if the brain shows signs of contrast leaking into areas it's not supposed to, we know there's been damage to the barrier that separates the blood in the brain. And that's a sign of dangerous inflammation, and that's a sign that the boy should be evaluated for cerebral ALD and for bone marrow transplant. I have a question here. Are there any dietary guidelines for boys with Addison only or AMN type ALD that families could implement for their sons? This is a really good question that we get often, and there are no what we would call evidence-based guidelines, meaning we don't have good scientific studies to say that one diet is better than another for ALD. We do know that Lorenzo's oil does lower very long-chain fatty acid levels, and then there is some evidence it can help men with and potentially women, theoretically, with some symptoms of worsening of AMN. But the best we know about Lorenzo, the best data we have on Lorenzo's oil really suggests that it reduces the risk of brain inflammation before it begins. Beyond that, I think we don't have a lot more to say about it in adulthood. Dietary guidelines in terms of foods to avoid or foods to consume more of. We do have a wonderful dietitian who's going to be offering a webinar session in the coming weeks, and I have to admit, I think she knows much more about dietary advice and guidance than I do, and I probably defer to her. My general advice to patients is to try and eat a diet that's high in vegetables and lower in most fats. But I think we'll be welcoming our dietitian from Kennedy Krieger Institute in a few weeks, and I'm sure she'll be able to answer those questions in more detail. Question here about what are the chances that someone with AMN will develop cerebral ALD? That's a good question, and I know that one that preoccupies a lot of men with AMN. The good news is that from year to year, your chance is much lower as a man with AMN than as a boy with any form of the disease of developing brain inflammation. The bad news is that men are really at risk of developing brain inflammation. This risk seems to increase slightly in the 20s and 30s and falls a bit, such that relatively few men over age 40 seem to develop cerebral ALD. Again, for reasons that we're not sure of. So I would say, yes, you do have some chances. It's a 20 to 25% chance overall that men will develop cerebral ALD. But as you get older, moving beyond 40, your chance does drop quite significantly. And another question here, can any lab test for very long-chain fatty acids, or does it have to be a specialized lab? So this might be a question that your doctor may have for you, or perhaps someone is wondering about whether the test that was sent was accurate or not. And I can say that there are many labs that actually do a good job of testing for very long-chain fatty acids. There are some with more experience than others, but generally speaking, as far as I'm aware, most of the labs that most physicians are sending to do a good job of testing. Those would include labs at the Mayo Clinic, labs at Kennedy Krieger Johns Hopkins, and many other commercial labs around the country. So the odds are, whether you're in Europe or the US, if your doctor is sending very long-chain fatty acids, they're probably sending it to a lab that is qualified to do it. So if the test comes back normal or abnormal, it's probably accurate, although I think if you or your doctor are uncertain about the quality or of the lab, you could try resending it to one of the more established labs, which would include the Mayo Clinic or Johns Hopkins. Another question here. I'm a carrier, 46 years old. What can I expect? I have some problems with my back, leg, and legs, and some pain and numbness. So it sounds like it's coming from maybe, as a carrier, so maybe from a woman with symptoms. And generally speaking, as mentioned earlier, women have usually milder, slower progressing symptoms, but they do have symptoms of back, of various pains, stiffness, and bowel and bladder symptoms. I think specifically you might be asking what you can expect in terms of will your symptoms get better or worse. And the course in general is variable. Some patients remain very stable for periods of time, but over the very long period, the symptoms usually get somewhat worse. The rates at which they get worse can vary. So it's hard for it's hard for any of us to predict what what any individual's future may hold in terms of the rate of progression. But in general, the tendency is that symptoms don't get better on their own. In some cases, in most cases, they do get a little bit worse on their own on AMN. Question here: will there soon be treatment for adult males with cerebral ALD? That's a great question, and I think thoughts on this are maybe I will see if anyone is willing to field questions here, but I will. I'll say that the process of bone marrow transplant in adult men would seem like a very logical one because it works so well in boys that we might consider it in adult men. It has been tried. It has been effective for some men. The difficulty is that men with cerebral ALD have more symptoms related to AMN than boys do, and it does complicate the process of bone marrow transplantation, which can be a very tricky and very dangerous process. So men who've been transplanted have had more trouble with complications from urinary tract infections and other systemic infections than boys have. And so it has been a more difficult challenge. Let me see if any of my colleagues here have anything they'd like to add to that statement.
Hi, this is Florian Eichler. Yeah, so I echo what Keith Van Haren said. I might want to say that we're getting better and better at transplantation in the adults. We are learning from the experience in children, but also cognizant that the scenario is different in adults with cerebral ALD. We found that particularly being non-ambulatory is a high risk factor going into a transplant, and there's a lot of experience that's coming out of Europe where probably the largest number of adults have been transplanted. We've transplanted a few patients, adults at MGH, and I think with every transplant, the care is getting better. So I think in the coming years things will improve there too.
Thanks, Wayne. I see one additional question here. It says, the very first schematic of the ALD proteins confused me a bit. Could you review it? Is that schematic a model of cell or DNA? Or what again? Thanks. Maybe just a brief review will clarify. Go back to the schematic for us. This was what we're talking about here. This is a cell. This is a nucleus. These are the chromosomes. This is the DNA coming from the chromosome, which codes for genes. Those genes code for proteins. And I think I can go on to say that this schematic here was a schematic of the ALD protein. The schematic here was a schematic of the cell, which is building very long chain fatty acids naturally, as it normally does, but unable to break the very long chain fatty acids down due to a defective protein. And as best I can tell, this is, I think, the end of the questions. Okay, so I think we're going to call we're going to end the session here, and we will end the session here. I wonder if I've been muted for some time here. My apologies if I have. Okay, we will catch up next time. Thanks. Somehow this became muted. For Christ's sake. I wonder if it did when I unplugged.